Thank you for all speakers. My question to Dr. Khalid Al-Dadi, I'm Mohammed Hassan Sabadiyah, the gastrology. Regarding H. pylori, what's about for the failure if there any family history or the H. pylori occurs in the family? Because I noticed that the recurrence of failure, that one of the parents are affected. So before to go to the second treatment or third treatment, I should screen family because H. pylori is intrafamilial cholesterols. Do you agree with that?
Thanks, Dr. Mohammed. Actually, you are right. We know that H. pylori is transmissible either oral to oral or oral to fecal. And it is like any other infections that can be transmitted by this way. We have to check, because if the first time failure, we have many reasons actually for that. This is one of the reasons, as we mentioned in the presentation. But I didn't actually find in the guidelines that we have to screen. So once we got the first time failure, yes, I agree that maybe we can screen for that, because H. pylori actually it is a common, and especially in developing countries, and even the way of transmission is due to fecal oral method. This is your concern, doctor? Okay.
تفضل دكتور. مايك فور دكتور قرشي.
Assalamu alaikum wa rahmatullah. Question regarding test and treat approach. I think in the kingdom now, as we saw from the study that presented by Dr. Raddadi, the prevalence in Saudi Arabia is more than 20%. But I saw your algorithm, Dr. You presented that you said you have to decide, is it less than 20 or more than 20 to test and treat?
It's not a must actually, it's a recommendation. Not everybody has to follow this. It's a recommendation, it's not a must.
Okay, this is a recommendation maybe by the American...
Yeah, it's American recommendation.
American recommendation. Yeah. So, but you recommend now, after the percentage that we saw, that we should go for test and treat, and this is actually what we are doing in the practice. We test our patient if they presented with dyspepsia. If they are positive for H. pylori, we go straight forward for the treatment, and this is our practice. So I think maybe you recommend that also.
No, but I could not understand the last part.
The last part I said we go with the test and treat. In our practice.
الصحفي during her presentation divided the population into two groups. Some of them to follow the test and treat, and others just treat.
If more than 10%, like in our area, we will go for test and treat. That's what I say.
So you agree with us? This is the name.
Yeah.
Okay, thank you so much.
Any question back in the female side? At the end, please. Just raise your hand, please.
Maybe I have a comment regarding the prevalence. Most of the studies done, and at least that I'm aware of, in Saudi Arabia, it's prevalence in patients with GI symptoms. There is one also study among medical students and showed the prevalence, which is young population, which is as far I remember, 25-year-old. This is the mean age. It was 35%, so it's still high prevalence in our area. And that's done using ureaplet test among 300 medical students in King Khalid University Hospital. This is one thing. The second thing is the test and treat, probably for internists and primary health care. Probably as a gastroenterologist, must come the patient being referred to you, and we know that how difficult it is to have the patient. Probably most of us will go probably and do EGD more than test and treat, because it's always difficult really to follow these patients. So as a subspecialist, although I totally agree with the test and treat in our country.
Assalamu alaikum. My question is for Dr. Ashwaq. You were talking about endoscopy and a patient over 55 with alarming symptom. So just being over 55 with dyspepsia is alarming because some slides were or يعني 55 or with alarming symptom or it is enough خلاص يعني that he is over 55 with dyspepsia to refer him for endoscopy.
Excuse me, raise your voice.
I'm asking about patients with dyspepsia who's
Yes, we will do
over 55.
endoscopy for a patient who's older than 55 or having alarm symptoms. What is the question?
My question is the age, يعني age-wise خلاص it's an alarming symptom already that he's having dyspepsia and over 55 even if there is no يعني weight loss.
Even without alarm symptoms. Any patient more than 55 years with or without alarm symptoms, we will consider AGD in this group of patients.
I think maybe دكتورة this يعني approach يعني gonna be very يعني expensive and يعني overloading for the main hospital if we refer all patient over 55 without even يعني trying to treat first and then if no response we will refer
Actually,
to
we are doing this because of, as I said, because of the risk of malignancy increases after this age.
So يعني I can't
Yeah.
مثلا treat for a month or two and see if there is no response I should refer immediately for endoscopy.
I think if the patient is having the symptom for a very long time, more than 1 or 2 years, for example, not new onset dyspepsia, we can consider this strategy. But if the symptoms are new, just for a few months, we have to do endoscopy for this patient. For new onset dyspepsia, I think endoscopy should be considered first, without empirical trial.
Okay, thank
The
you.
burden of the malignancy is usually of the stomach cancer is a little bit advanced and bad prognosis if we discover it late. So early pickup is our role as family physicians instead of waiting for the patient for years.
Thank you.
Doctor, please.
Dr. Ahmad, family physician. Thank you for this nice presentation and interactive one. Just I want to clarify, nowadays we notice children have this GIT symptoms. Which age we can investigate and we can start therapy?
Your question is to whom, please?
As a general, for pediatric population.
Pediatric?
Yeah.
Ah, okay. Can you repeat your question?
Okay, nowadays children we are seeing them having dyspepsia or GIT symptoms. Can we investigate them for H. pylori and with which age we can start regimens therapy?
You can go for it, Dr. Ashwat. His question is about treating or testing pediatric age group for H. pylori.
No, actually, I have no data about this one. Somebody else?
Dr. Jibreen?
Pediatric, I don't know.
Dr. Hassousa? He is on the phone. We will wait for Dr. Hassousa for this answer. Dr. Qurashi, تفضل. There is another question in the female side. Is it a question or comment?
Question.
طيب بس الفيميل side another chance, please, yeah.
Okay, thank you for the presentation. My question is
Your
for
voice, please.
my question is for Dr. Ashwak. Who should be offered retesting for eradication for H. pylori?
Sorry.
For confirmation of eradication.
Well, there is a problem in the echoes of audio here. So can you just repeat the question?
Who should be tested for confirmation of eradication for H. pylori?
Any patient who receive treatment, it's recommended to confirm eradication. Although some physicians are not doing this, it's recommended to confirm eradication once you have given therapy for the patient.
Dr. Hassousa, there is a question for you. Yes, welcome. One of the attendees is asking about the best approach for pediatric age group regarding H. pylori testing and treating. The mic, please.
Regarding the pediatric H. pylori, we have, we call it NASPIC and guidelines, North America Pediatric Gastroenterology. Usually, if the child is symptomatic, we should do screening, including either stool, H. pylori, or urea breath test, and we should treat it. However, it's similar to the adult. We have classified risk groups like stomach cancer, peptic ulcer disease, but we don't usually treat with asymptomatic H. pylori. So if the child is symptomatic with risk factors, we should investigate, and usually the gold standard for H. pylori in pediatrics, either flow test plus biopsy. It didn't depend on only biopsy. We should have rapid urease test plus biopsy, or culture and biopsy. Usually we should have combined of the invasive procedures.
Okay, thank you very much. I will conclude this.
Kindly, Dr. Hatusa, will use the same regimen for adult as for pediatric?
Yes, and we usually use PAC, proton pump inhibitors, amoxyl clarithromycin. We have our own studies going for looking for what's the resistance, but most of these patients, they have failure because of the family history of H. pylori. They didn't respond, or they have recurrent H. pylori. This is why I asked Dr. Haddadi about the adult maneuver for screening family of H. pylori.
I will conclude this session. Thank you all, and we will have a 10 minutes break and then resume back so we can proceed, inshallah. Thank you all.